Hello, everyone. Our apologies for the technical issues that we had with the platform. So we're going to go back to Dr. Rick Miron, and we're going to be stitching this part of the lecture with the previous part and put it all together. Rick, you're all on. So you can continue the presentation, please. Thank you.
All right. Welcome back, everyone. So where we left off, and I think even if it's not exactly stitched together perfectly, I think this table right here is very important for the average dentist that wants to learn more about platelet concentrates. When you actually look at the density of these cells, have a look at platelets, have a look at white blood cells, have a look at red blood cells, and you can see that the white blood cells and the red blood cells are very similar in size. So that's number one. The platelets are lighter, so they go to the top. But I like to show the frequency distribution. So per microliter, in 1 microliter of blood, you have 200,000 platelets, 5,000 white blood cells, 5 million red blood cells. So you have by far the most amount of red blood cells. But look at the white blood cells. There's 5,000, 5 million. So for every 1 white blood cell, there's 1,000 red blood cells. And I call this the 1 to 1,000 rule because they're almost the exact same weight. As we saw previously, the size is very similar. Always remember for that one leukocyte, the 1 white blood cell that wants to make it to the top, to call it L pure F, or leukocyte and platelet-rich fibrin. For every one that's going to the top on a fixed angle centrifuge, there's 1,000 red blood cells that are coming down and trapping it from actually getting to that top layer. And that's what I call the 1 to 1,000 rule. So this is very important. And one of the reasons why it's much more difficult to actually accumulate these white blood cells when compared to platelets. Okay, so again, think of that concept now in those white blood cells. If he starts down here, that little 1 white blood cell has got to make it all the way to the top with all these cells smashed to the back, and there's 1,000 red blood cells that need to come down, whereas 1 white blood cell needs to make it to the top. And that's one of the reasons why it's not very effective. Now, I always say that platelet-rich fibrin is one of the most utilized material in dentistry that has the least amount of good quality research. And it's just been, a bit of a mix-up. There's been a lot of commercial debate on what systems are using, on and on and on. The reality is nobody's really ever done good research to investigate how layers separate, where cells go at different protocols, etc. And so we received a large grant to be able to specifically address the question, if I spin at 100G for 3 minutes, 5 minutes, 8 minutes, 12 minutes, what happens? 200G for 3 minutes, 5 minutes, 8 minutes, 12 minutes, what happens? 400G, 700G, 1,000, 1,200. And by doing this research, it allowed our team to really, truly optimize what is the best protocol to make a membrane, what is the best protocol to make a liquid pure F, to make a concentrated pure F, to make a, all these different protocols. And I can tell you, when you're a clinician and you look at this spun at 100G for 12 minutes and you get this much separation, and you look at this spun at 1,000G for 3 minutes and you get this much separation, these look identical. But the actual cell layers that have been separated here are completely different between these two layers. And that's one of the reasons why it's so important to do this research, number one, and number two, to follow, guidelines and protocols that have actually been tested and not just say, well, this membrane looks about the right size, so we're going to then use it thereafter. Now, when we spin, of course, on the horizontal, now we're able to accumulate the platelets, the white blood cells in this upper layer. And when we compare it to the original, LPRF protocols, it's night and day difference. Now we can actually make these membranes that have a lot of the cells in that actual, upper layer. So that's the biggest difference, and a lot of research was put into that. Again, for those that want to learn more about this, you can go to the Bioheat website. We literally put all of our publications available for download so that people can clearly see, with full transparency, what we've done, what kind of research we've done, on and on and on. And like I said, for those that want to actually follow a real platelet-rich fibrin program, we offer this online platform where course by course, there's 9 different modules where you can go through each of the sections and learn how to use platelet-rich fibrin correctly. Okay, if you're in Europe, we have a similar website, but it's biopuref.eu versus .com. So for those that live on that side of the world. Now, if you're interested, what's the difference between fixed angle versus horizontal? Again, we're not the inventors of horizontal centrifuges by any means. This was done in the PRP days with, Bob Marks, Arun Garg, and those guys all use these horizontal centrifuges. They're better at separating layers based on their density. They're better at concentrating platelets, whether it be PRP, PRF, or any of these fields. If you want to learn more, just go on Google, type in fixed angle versus horizontal centrifuges, and you'll have all of these websites that come up. And when you go through these, you'll very clearly see the horizontal swing out rotor is particularly useful when samples are to be resolved in density gradient. So that means you're separating the cells based on their density, which is what we're doing in PRF. Platelets, the light guys go to the top, middle guys, white blood cells to the middle, red blood cells, heavy cells to the bottom. The longer path length permits better separation of individual particles. However, this rotor is relatively inefficient for pelleting. So I'm going to explain to you what pelleting is, because for pelleting, it's better to use the fixed angle centrifuge, and that's what they're utilized for. So pelleting means that you send all the cells to the bottom of the PRF tubes, and I'll explain to you why this is better with the fixed angle centrifuge, okay? So very simply, when you actually pellet, you're sending all the cells to the bottom of the tubes, and I'll give you an example. If I have a solution, and the solution has a lot of stem cells in the solution, well, I might not want that much liquid. If I want to send all the cells to the bottom of the tube, I can use a fixed angle centrifuge to pellet all the cells to the bottom. Then I remove the liquid and I just keep the little amount of stem cells. The reason why it's better on a fixed angle centrifuge is that if I want to send all the cells to the bottom here, and this little stem cell's floating right here, if I want to accumulate them all at the bottom, on a fixed angle, he just goes boom against the back wall and then all the way down to the bottom. And then you can pellet. So it's very quick because you go doom and then down to the bottom. And that's why you see here, even when you pellet, oops, let me go back here. Look at where these cells are found. They're all found on the back wall, on the angle, all in the back on that angle, right? So they pellet. If you try and pellet on a horizontal centrifuge, the problem is that little stem cell that starts here, he's got to go all the way down to the bottom here before you can accumulate them. So it's not very effective to do it on a horizontal centrifuge to pellet. It's much more effective to do it this way here. Now with PRF, you're not trying to accumulate all the cells at the bottom here. You're trying to separate based on gradient difference in the upper layers. That's why it should be done scientifically with a horizontal centrifuge. I mean, it just makes a lot of sense. But like I said, a lot of us have been trained to use these fixed angle centrifuges here. We've talked a lot about the difference in the longer path, which means bigger separation between the RCF min and RCF max. I didn't realize this part here until I was reading online one day, and this is directly from this website here, Drucker Diagnostics. Larger radius, higher RCF, shorter spin times. Tube centrifuge and a horizontal centrifuge experience a larger radius, resulting in higher RCF and more efficient forces. Higher G-forces produce a better seal with the tube wall due to better gel packing. But this is important here. The time required for complete centrifugation is only 2/3 of the time required on a fixed angle centrifuge. And then they show this picture here and they say, if you go horizontal, this protocol will take you 10 minutes. If you're fixed angle, it's 15 minutes. So you save some time here. Now, when you do this, it's not that you're just saving, 5 minutes or 4 minutes, whatever it may be in this case here. It's the fact that when you go horizontal, you can actually separate these layers a lot more effectively and more quickly on a horizontal centrifuge, which means that before the PRF actually clots into a fibrin clot, you want to separate these cells as quickly as possible to that correct upper layer, okay? When you do it this way here, you can really achieve this much more effectively, which I think is more important in PRF world. It's not just that you're saving 5 minutes here, it's that you're getting all the platelets and the leukocytes in that upper layer before this tube actually clots and forms a fibrin clot. Okay, so I think it's relatively important there. On the Eppendorf website, gradient centrifugation definitely requires a swing up bucket. Okay, so again, if you want to separate your cells based on their density, which is what we're doing in PRF, you definitely need to use one of these swing up buckets here. Okay, now people will ask, how much more effective is that? From our studies, when it comes to white blood cells in particular, they're about 4 times more effective. So you can get up to 4 times more white blood cells when you spin horizontal versus fixed angle. Okay, so it's a big difference. Now, tubes. Let's make these tubes more hydrophilic. How do we do that? So I want to show you some stuff in research that we've done. So first of all, when it comes to these tubes, I want to show you a few videos that are very, very interesting, okay? So we're just going to turn off this video. I'm just going to go through it a little bit faster. I remember doing research some time ago where we were actually trying to figure out how to make the vacuum stronger in these PRF tubes. So we were actually putting the needle, instead of in a vein and collecting some blood, we'd put it in a bowl of water. And then we'd start collecting and literally counting, so timing how long it takes to fill a tube. So we go, this tube takes 15 seconds, this one 10 seconds, this tube's 25 seconds. And while we were doing these experiments, it was shocking because we were doing the testing with all these different types of tubes. So there's the intraspin tubes, the APRF tubes, the different types of tubes. When we were doing this research with a new batch of APRF tubes, it was actually shocking to our group because this was about 1.5 years ago. And these tubes are not expired. They're directly out of the box and directly out of the packaging. And we were filling them up with water and we were running our tests. And then all of a sudden, all these bubbles came up, all these chemicals that were added to the tubes. And I was just blown out of my mind. I said, but why the heck are these tubes here and none of the other ones actually foaming up with all these different chemicals inside of it? And as it turns out, according to the manufacturer, there's silicone that's added to the tubes, which is an additive that is unnecessary. And one of the things that was even more shocking was that my group, and particularly a lot of our studies that were done by Masako, Fujioka, Kobayashi, and colleagues, we used a lot of these APRF tubes over the years. And so we had many, many batches of APRF tubes. And here is an example of research that we were doing many years ago. These are the same APRF tubes. And you'll notice here, this video was made in 2019. Look at the year here, 2017. Okay, so this is back in our research papers that we were working on in 2015, 2016. We were using these tubes, both glass tubes. And sure enough, when you'd fill these ones here up with water, there's no chemicals. And that's where we were producing the better results with these tubes. And then all of a sudden, like I said, online and everywhere else, we started seeing these different comments that were being made. Anybody using Chacrun's PRF system having increased risk for infection or increased pain versus non-use, they would show these and look, there's 170 comments here. And it wasn't until several months later that the Japanese colleague, Dr. Tomo Kawase, started doing more research on these tubes and evidence for contamination of silica microparticles in advanced platelet-rich fibrin matrix prepared using silica-coated plastic tubes. And so the research that he was doing was that he was producing these PRF membranes following centrifugation in different types of tubes. After the fibrin clot was made, he put it on a petri dish. He would do enzymatic digestion of the fibrin, get rid of all the fibrin, and whatever was left over, whatever particles were left over there, he would then look at under a microscope via scanning electron microscopy. And sure enough, you saw all these different chemicals. And that's when our group said, well, we don't want any chemicals because we don't want to put chemicals back into a patient, number one. Number two, we've learned that the more hydrophilic an implant surface is, the more attracted it is to platelets. The more platelets are attracted to it, the better the results for osseointegration. In theory, we should be able to make better clots if we make a more hydrophilic tube. In this video here, I want to show you some of the research that we've done over the years because this is 8 different types of tubes. Okay, they're all red top. They all look very similar. There's little differences here. So you can see this glass is a little darker than this one. But the bottom line is in these studies, we're testing different hydrophilicity of different tubes. So we're doing different chemical treatments of the tubes, different processing techniques, different mixtures of glass. You can do many different things to try and create a more hydrophilic tube surface. And so in this video here, I basically just explain all the research that we did. And I'm just going to fast forward and go directly to the video. But long story short, I explain differences. Now here's some intraspin tubes. And what I did in this video is that I purposely had my blood drawn all at the same time in a random order. And you can see here, there's different types of tubes here. The first one is an APRF tube. The second one is a glass tube. Intraspin number 3. Number 4 is glass again. So I drew them up in a random order. I'm having my blood drawn here, and I'm just going through the video quickly here just to save some time, okay? And then we put them in the centrifugation device, an 8-minute protocol, and then I explain the water test here. I'll just go to the very end. I want to show you guys the results here. Okay, at the very end of this video, okay, here. okay, after the spin cycle. I'm now taking out the tubes, and watch what you'll see here, okay? When you spun using the newly designed hydrophilic tubes, have a look at this. 8-minute spin cycle on a horizontal centrifuge, you can take the tube and put it directly upside down. It's fully clotted, okay? That's not because it's my blood, you know, it's only because of the hydrophilic surface of that tube. And again, I always say tubes are more important. People are paying 85 cents to $1.35 US for different types of tubes. There's not a difference in the price of the tubes. They're all very similar in pricing, but the quality differences are massive, okay? And it's amazing, like I said, this is my blood drawn at the same time. Look, this is a different type of tube, the intraspin tube, still liquid, okay? It's the same person, me, the same blood, taken at the same time, everything's identical. The only difference is the tube surface. And again, here's the other one, the glass tube. So I drew 2 of each, and look, completely clotted. Don't even need to pop the lids. Like I said, it's a pure clot. And that's just understanding the science behind how these tubes clot. And I remember after I showed that video, you know, I started getting people posting on Instagram and other places all these cool pictures of people putting the tubes upside down and saying, you know, sending me comments, etc., for the development of these tubes. Now, when you look at this, look, have a look here. Right away, when I look at this image, I can tell right away that this was spun on a fixed angle centrifuge. All the cells are banged up on the back here. That's a fixed angle. Horizontal, right? Horizontal. I can tell right away what people are spinning on and what kind of results are to be expected. But the tubes, like I say, make a very big difference. I'll go back here. These were just comments that I received from different colleagues. I got to admit, these tubes are a game changer, incredible results compared to the obviously inferior tubes I was using. Thanks, Rick Miron, for the opportunity to try these. I'll definitely be using these BioPure F. This is an actual speaker for Intraspin who did a lot of work with Intraspin, Steve Venia. And Rick, we finally tried your tubes. What a difference. The clots were huge, so much that my beautiful assistants could turn them over upside down, no fear of mixing. Way to go. Okay, so like I said, tubes are very, very important. Of course, we've done a lot of the science to show how much bigger these membranes are, et cetera. So if anybody wants to see the science of how this works, we have that all available in publications. But clinically, like I said, if you're one of these people that doesn't always get a clot or gets a medium-sized clot or et cetera, get tubes that are actually more hydrophilic that are meant for the production of platelet-rich fibrin. It makes a big difference here. And of course, you never want to put any type of these silica microparticles or contaminate your patients by using some of these lab tubes that are not meant for human use, okay? So big differences there. And actually, like I said, the Japanese colleague actually showed that some of those chemicals actually make human cells go through apoptosis and actually kills them. And he showed a really nice study just showing how bad actually having these chemicals are for cells. And if you're not sure, like I said, I always say just perform the water test that we were doing. So either you can grab a little bowl and put a butterfly needle and just check to see yourself. You can literally just take your tube, pop the lid, fill it up with about, you know, a quarter water or a third water, and just mix it, shake it vigorously. If you start to see a bunch of bubbles that are forming, there's chemicals in your tube. If you shake it and it just shows water, then there's no chemicals, okay? So I highly recommend that people just check to yourself because you're putting it in patients, you know, you might as well know what's going on inside. Now, one of the more recent developments that we've been doing and working on very heavily has been with respect to the Bioheat technology. And this is a newer technology where when you separate these layers based on their density, you can actually heat the plasma. And instead of having a membrane that lasts 2 to 3 weeks, you can extend it to 4 to 6 months. Okay, so there's been a lot of work that's been done. It looks completely differently. Like I said, now it's, you know, it looks like a gel, which is different in its appearance. And you can make these membranes now that are called, we've been terming them AL-PureF or E-PureF for extended PureF membranes, and been using these more recently. This was a study that was done by Professor Gano or Dr. Gano in Italy with some of his colleagues out in Brazil. A very nice study that was recently published in Platelets, where they looked at using PureF on one side versus using the albumin PureF on the other side. And you can really see that after an extended period of time, so this is more representative several months after, it's still there. It's biocompatible. You see blood vessels growing around it. And so there's quite nice results that are being done. And Misako did a nice study where she characterized growth factor release from these. And I think ongoing, like I said, there'll be more and more research that's being done on this topic. The way that it works, you do basically take out the upper layer. And of course, the protocols and videos are all available. So if anybody wants to know how to do this, I'm more than happy to share how this is done. You take out the upper layer, you then heat it, okay? After the heating process, it looks different. So it's now been heated. You then cool it. We typically use the BioCool device to cool this. We then mix both layers together, okay? So back and forth, we will mix these. And then you have what's called the albumin gel. So this is in Bern, Switzerland, that we were doing this about a year ago now when I went there in August 2019. And one of the goals that we were trying to do was create these membranes that are longer lasting that could be utilized for GBR procedures as membranes over top of titanium meshes. So this can be injected and it's utilized in facial aesthetics. It can also be, for example, placed on a Petri dish and utilized on a Petri dish to create membranes. And these and you can see the consistency right away. It's very different than typical liquid puref, so the consistency is very different. You can create these membranes now of different shapes and sizes and then use them as barriers that'll last 4 to 6 months as opposed to 2 to 3 weeks, which is a quite nice technology. Okay, so again, looks very different from your standard membranes, but has much more extended resorption properties. And we've created these little trays here that can then be utilized. So for example, if you want to make something for a diabetic foot ulcer, you can use this one here, a circle. If you want to use it for gingival grafting, you can use a long one and pass it through a tunnel, or some little squares for horizontal ridge augmentations, extraction sockets here. So there's different shapes here that you can create, you know, different size membranes depending on what you want to achieve and what you want to do. Okay, so this is just the process. Again, this is a little demonstration from the paper of how to do this. And like I said, one of the growing fields and uses is in facial aesthetics, where, you know, we've had many colleagues that have begun to use this type of technology. In this case here, this is a case that was done in Naples, Florida by Dr. Dobaccio, where he uses a combination of laser therapy with the Photona laser and does smooth lays and lip lays and different technologies, as well as some injections that were done. And you can really achieve a big difference in some of these aesthetic results. So quite interesting here. And like I said, Dr. Davies, who's one of the lead educators in facial aesthetics, doctor, an actual medical doctor, teaches how to do a lot of these procedures here. So for those that are interested, you can learn more at PureF-EDU, as well as you can create these membranes that can then be utilized as an outer barrier. There's the extended PureF membrane on the outside. On the inside here, we have the sticky bone. Okay, so it's very interesting. And then you can go to a ridge and just tack that onto a ridge where the sticky bone is on the ridge on the bone component, and the extended PureF membrane that lasts 4 to 6 months is on the outside. And then you no longer necessarily need a collagen membrane in such cases. So, you know, very interesting and exciting technology. One of the things that was developed more recently was these little BioCool devices. So these are little coolers where you actually take the liquid PureF and you actually place it inside this little BioCool device. And this is a little cheap device. It's only $89 US, where at a specific temperature, it'll double the working properties of liquid PureF. And so when you do these mixtures where you're mixing the liquid PureF back with the albumin gel, which has been heated, a lot of the times to make this go a little bit faster, we put it in a little cooler and then it just cools these down. One thing that we've learned is that it'll actually double the working properties of liquid PureF. So instead of clotting in 20 minutes or so, this will extend it to 40, 50 minutes, keep it in liquid formulation so you can still inject it. Very, very useful for those that are working in the facial aesthetic field. Okay, so again, a nice newer technology that's been developed more recently. One thing that I wanted to share with colleagues, I'm at the very end now, is that I've been posting more explanations of how to do a lot of these different protocols and been posting them, and they can be shared as well in the Global Implant Summit group, etc. But it's very loud here. Basically, what I've done is I just
when you want to make a biograph,
people so how to do these protocols. So, for example, if you want to make these larger membranes, with these ones here we call biograph membranes, these are all available on Facebook. So, literally, I don't try and keep the protocols hidden, or, take my course and I'll give you the protocols. I just put them all online. So for anybody that wants to learn them, they can see the different protocols, what speeds we work at, what equipment we work with. And then in the actual videos, it literally goes through all the protocols. Okay, so you'll see here, as I fast forward through, it literally explains step by step. Step 1, this is what you do. Step 2, draw out the liquid pure F, place it in the little bioheat tray, and it goes step by step through every one of these protocols. And there's 10 different ones to allow people to make the bioheat, extended pure membranes, the fillers, these types of big biograft membranes, how we make sticky bone. It just explains every one of these steps from how we go from the very beginning to get these types of biograft membranes here. Okay, so for those that want to learn that, that's available in the Next Generation Implant Dentistry Facebook group. As well, our online program, which is available at purefedu.com. If you want to learn really completely how to use PureF, there's a 6-hour program that has 9 modules. Typically, we offer it for $595 US. But as a result of the collaboration with the Global Implant Summit, I've made it free. So if you go online to puref-edu.com and you go to the coupon code, and instead of paying $595, you can just enter in this code GIS, and it'll give you free access. And that will give you access to all the modules, explanations, protocols, science behind PureF, and really how to use it in dentistry, how to use it for gingival grafting, extraction sockets, sinus grafting, GBR procedures, the whole works. And we made this available, and we made this online program simply to try and help colleagues out to better advance the field. So that's the last slide here. I just want to thank everybody for your attention. Again, if anybody ever has any emails that you want to send me, this is my email address here, rick@themironlab.com. And again, for those that want to learn more about PureF, the website's purefedu.com. Thank you.
Rick, you definitely made our job and career 10 times more interesting with all what you're showing and what you're doing. Let me ask you a few questions I have in mind, and let me know your thoughts about that. Do you think in the future we're going to be seeing more changes in the implant design itself to acquire this hydrophilic and volume of the PRF to be introduced at the same time with the surgical techniques of placing the implant itself?
That's a very good question. So it's funny that you asked that question, because my master's research project was actually that topic specifically.
Yeah.
And so when I was in Canada, and the reason why I won this big scholarship was that I was this biological guy that was combining these implant surfaces and trying to figure out how proteins would actually absorb to the implant surface.
Yep.
And I was doing that with the enamel matrix derivative, and I was doing that with PureF, and I was doing it with BMPs. And every protein is very different. Some are hydrophilic proteins, some are hydrophobic. Some do it better at different pHs. It's a nightmare.
Yeah.
Long story short, I spent 2 years figuring out how to do this, so then I can get my Emdogain onto this implant surface. And then we were all excited. We showed in vitro that it improved on and on and on. And then you know what happened? We went to the animal models, and then we were putting these implants in that were coated with these different growth factors and screwing them in. And as we were screwing them in, all these proteins get sheared right off the surface.
Oh, really?
So we had done 2 years of work only to find that that was a complete failure.
Even with concave implant designs or like porous, nothing really.
It was very, very difficult. Maybe with more porous ones, we could make some advancements, but these were all done with SLA active implants, which have a somewhat porous design. But it was just it didn't work out very well. Long story short, I don't know how much impact that will have. What I do know is that when you use PureF in implant dentistry, when you use it around the soft tissue, that's where the real benefit is, especially in immediate implants. So for example, when you place these 5mm implants into these 10mm holes after a molar extraction, right? You place a 5mm implant in there, you got a 10mm hole, you got 5mm, so let's say 2.5mm around that entire implant, which is just a hole.
Jumping distance is high.
About it because those bacteria from the oral cavity want to go in there and attach to the roughened portion of the implant surface. And that's where having a PRF membrane and just wrapping it around that opening is very useful to help with the soft tissue healing there. Okay.
Yeah,
so
a mesh for the jumping distance to jump in. What's your thoughts about like patients that are using, for example, bisphosphonates or osteonecrosis, and how the PRF really helps during that?
That's a good question, actually. And in fact, one of our collaborators, Carlos Mura, we had written a systematic review on that topic specifically. I think we had close to 15 studies or so, and we tried to get it published. But, you know, the problem in that ONJ field is that most of these studies are not randomized clinical studies, right? They're just case series where they say, look, I've used PRF in this 15 times in a row, and I had these results. And in the scientific community, they like to have these randomized studies where on one side you do just this, and on the other side you add PRF. And so actually the paper was rejected. And to this day, like I said, you cannot state that one modality is better than the other scientifically. There still needs to be more randomized clinical trials on that topic. Now, the problem with that is that when you have ONJ, it's a very serious case. And you want to do everything possible. So a lot of these clinicians that work in these hospitals, they say, we're not doing a randomized study on this. We're just doing the best that we can for our patients. And we're not going to risk, you know, not using PRF in this case just to do a study. I mean, that's completely crazy, right? So different people have different philosophies. And in that space there, I think it's very hard to give real science-based answers. But long story short, it just makes sense. A lot of these diseases are low blood flow, right? When you have ONJ, for instance, you have a soft tissue defect now, and PRF is better for soft tissues. You have a lot of times some kind of bacterial contamination, so having leukocytes is advantageous, and you have dead bone. And your job as a clinician is to remove the dead bone and try and revascularize the area. So if you add PRF there, of course, there's going to be some benefit there as well. So I think it makes perfect sense. I thought actually that article was very good. It was logical. And it's too bad, like I said, we should probably submit it somewhere else because I keep thinking about it and it's just sitting there doing nothing. But you know, there's many of these fields like where it's logical, it's just not confirmed based on science.
Yeah, PRF and Schneiderian membrane or enteral communication and the benefits and helps. Your thoughts?
Both of them can be utilized. Of course, there's been a lot of case reports that people have used it for oral antler communication, so that's been well documented. For sinus perforations, the rule of thumb that the group of international colleagues kind of gathered and stated was that if the Schneiderian membrane tear is 5 millimeters or less, you can use PRF. If it's larger, you're better off covering it with a collagen membrane. And the one person that I could recommend learning that from is from Dr. Michael Picos down in Trinity, Florida. He invented maybe 20, 25 years ago a technique where he actually covers the Schneiderian membranes with collagen and actually does external fixation on the lateral walls. It's very cool the way that he does it. And has been teaching that for more than 2 decades. And I highly recommend using it that way there.
When you lay back and just start to imagine things, how all what you're doing is going to be affecting the implant future 10 years from now, what your thoughts are going to be?
Honestly, I just think as people team up together and work together as a team, obviously the more advancements can be made. There's no question. Everybody has a different skill set. Some people are excellent clinicians, other people are researchers, some people work in labs. I mean, the more these people can work together as a big team, obviously the faster the field can progress. At the end of the day, like I said, there is a patient sitting at chairside for everyone. And when we have newer technologies, my feeling is just to give out as much of the info to help other people out. I mean, that's the reason why I give a lot of these programs out for free. Paper downloads, I put them on the Bioheat website for free. You know, you don't have to pay them the money for them. And, you know, we try as much as possible to advance the field as best we can. And we'll see how things go. Like I said, I know one thing for sure. The more natural you can go with your regenerative strategies, the better. Right? That's obvious. And so if we can make membranes that are made from your own blood that last 4 to 6 months, as opposed to using a membrane from, you know, a cow or a pig, of course that's going to be better, and it's cheaper, and your patient's going to be happier. I mean, everybody wins if it can be done. And so it's really a matter of, one, getting the research done to really show where it's working. We have to be as evidence-based as possible, so we have to do the studies. And we have many, many people from around the world now that are working on these technologies. In fact, amazingly, like I said, I was just with Craig Mish about a couple of weeks ago, and just, he was interested in the technology and having these, monsters, these huge guys in the field, even interested in doing some research with this stuff and using it as just a huge proponent to what we believe in, and we'll see how things go in the future. So I just hope we can rapidly get the data and then transfer it to everybody. The beauty of the internet is that now you can transfer knowledge so fast, right? Like these webinars can be viewed by a couple thousand people that will say, wow, I didn't know that was possible, that you can heat plasma and make this membrane. And so, it's amazing, like I said, how fast things can grow, and we need to find people to help educate, doing other things. So
your lecture was amazing, and your work is even more amazing, and I think an enormous amount of people just benefited from all your lectures now. I'm just waiting for a few more questions. If anyone have any questions, please start posting them on. We have Dr. Rick Miron himself here, so take as much advantage as possible from him. So give us a few minutes.
One of the questions here, it says, how many times do you mix Al Pure F with the liquid Pure F, the Pure F inside the syringe? Usually what we do is we use, they're called female Luer lock syringes. Okay, you buy them in the United States, they're about $1.50 each. We mix them back and forth about 10 times. The nice thing about it is that whenever you're mixing back and forth, you can actually feel the abdomen kind of break up. And as it's going back and forth, then all of a sudden the consistency gets much smoother, and then you can go a little bit faster, and at that point there that it's ready to be injected, which is quite nice. And then you can do the injections, especially in the facial field. Imagine if you don't break it up enough, when you inject it into somebody's tissue, let's say you want to do some injections here to lift the face, a lot of times it'll actually clump up in the syringe and won't come out properly. And you might get jammed up in the middle of your injection and be like, oh boy, now I got to pull out the needle, then I got to go back in. So it's a good idea to mix it, I would say, 10 times.
The viscosity is very important.
Yeah.
Dr. Peval here is just mentioning very generous offers, and thank you for the code and peer-to-peer collaboration. Any more question, guys? Let us know. What's your thoughts on sticky bone and the viscosity, especially working with it with the PRF?
So, one of the things about making a sticky bone membrane, there's a couple things. One, fibrin will actually bind better to collagen. So any type of grafting material that has collagen inside of it will work better. So if you make sticky bone with an allograft, it'll always work better than with a xenograft. So one thing that we've realized with teaching is that a lot of people will come back and say, hey, we used exactly the same protocol in Europe, but they look at their sticky bone. I'm like, there's no way you did that. And the reason why was they used a xenograft, and xenografts have no collagen, right? They're completely burnt out. And so that's one of the advantages. Another thing too with sticky bone is that if you actually take a PRF membrane and you cut it up into small pieces first, and then you mix it with, your allograft, then when you introduce the liquid PRF afterwards, it'll make a better sticky bone. And the reason for that is that fibrin always builds from previous fibrin. So if you have a PRF membrane right here, and I add liquid fibrinogen and thrombin, so that's the liquid PRF, if you want to call it that, you add it, the fibrin will start to build from previous fibrin, okay? So if I take a big membrane and I cut it up into a bunch of small pieces, then when I introduce the liquid, then it builds from all these little small pieces, and that clot will then form a nice solid sticky bone. Yeah, and that's the way that we do it. So we always say 2 PRF membranes, you cut them up into small pieces, allograft in there. If you need to use a xenograft because of its non-resorbable properties, that's completely fine. Just make sure you have either autogenous bone or some collagen, and then you mix it thereafter, and that's the better way to do it.
Beautiful. You're implementing the science with the clinical skills beautifully. Any more questions?
I see one there from the glass tube one.
Yes.
Yes, the glass tubes are much, much, much better. We've done research with this, and quite honestly, like I said, there's literally a twofold increase in the size, the strength. My Chinese colleague, Yufeng Zhang, has been literally building tubes for 2 years, doing this amazing research, stuff that you would never imagine. He's doing things like the same technology that's used on implant surfaces to make them more hydrophilic, he's doing on these glass tube walls with no chemicals, okay? And it's amazing. Like I said, nowadays we can make these clots much faster, much stronger. And I highly recommend, like I said, using the tubes that are made out of glass, but it has to be glass that's treated in the right way. And so, you know, a lot of research there, no question. And if you're in Europe or another part of the world, like I said, you can get them at biopure.com and you can test them yourself. Like I said, the nice thing about the tubes is that you can literally take the tubes that we've developed, compare them to, you know, intraspin tubes, for example, that are the silica coated ones, run them side by side, do the exact same experiment that I did. Take blood from somebody and drop the tubes in a random order. So let's say you have 4 tubes, 2 intraspin, 2 Biopure F, draw whatever order you want, all at the same time, put it in the machine, same protocol, everything's the same. When you take those out, you're gonna see the membranes from our tubes are way better. Like I said, and the cost of the tubes is literally the same thing for all these companies. So it's amazing, like I said, the differences there. That's the biggest misconception in the Pure F world is how important the tubes are. People have no idea. Very, very important.
Going back with the implant design, other than just the surface itself and the microsurface shape of the implant, the microarchitecture shape of the implant, like if the shape of the implant in itself was having like some kind of a tunnel or pores or something to squeeze in something with the PRF, what would be your thoughts on that?
You know, my thoughts on implants is that they integrate very well. And my thoughts are, like I said, I worked with Danny Boozer for a number of years, and it was getting to the point where we didn't really know if we could make these implants integrate into bone any better than we already have it.
Yeah.
And what I mean by that is, you know, the research, if you asked that question 30 years ago, there was a lot of work to do. And I think all the work they've done with surface topography, as well as Stroman's work, which has been real pioneering in the surface technology, they've done great work. I don't know how much better that's going to get. And implants still fail today. Implants still fail today. And I believe that a lot of those implants that fail, especially the early implant failures, those are the ones that I'm talking about, is a result of your patient having some kind of deficiency in something. So it's like saying, if I place an implant, and the perfect example is somebody that's vitamin D deficient, well, vitamin D is vitamin for bone. And so if you have a patient that's vitamin D deficient, and that's the vitamin for bone, and you place an implant in that bone, and all of a sudden it fails after 6 to 8 weeks, a lot of the times it's linked to the patient, not linked to you doing your surgery. Yep. Okay. And as dentists, the problem is we're always looking in this little region in the mouth, and that's it. You know, we just go, what do we do here? And we often forget about how important a person's health is, their levels of antioxidants, vitamins, etc. And so I think probably as we move forward, dentists are going to be a little bit more cognitive of these points. I think that's very important for us because we forget these things, and they're becoming more and more important, especially in US, you know, and that was one big change that I saw between European to North American. It's a big difference. Like I said, Europeans generally are healthier. They're taking more holidays or less stress. US, we have to work harder. You know, we're grinding in longer weeks. We're eating more fast food, and all of a sudden, health-wise, you know, it's gone down. And I have a funny story to share with you. Actually, it's kind of a sad one, but when we were doing all this research with the vitamin D stuff, we were doing it in Europe as well as here in Florida. I was starting to go to some conferences to learn more about this. And the people that work, real PhD medical doctor endocrinologists, they were always shocked because life expectancy in the United States, it's one of the only countries and one of the only first world countries where life expectancy is going down, not up. Okay. If you look at all other countries, Switzerland, Italy, wherever else in the world, every year medicine gets better and better and better. Life expectancy goes up. If you actually go online, look up life expectancy in the United States, you'll see over the last 5 years, life expectancy is going down. Okay. Which means that if you have a kid that's born today, he's less likely to live as long as you will, which is just amazing. You know, it's completely backwards. And that has to do with, you know, stress, what kind of foods we put in our body, environmental factors, on and on and on. So I think that probably as medical doctors, you know, being dentists or doctors of the oral cavity, we got to pay attention to some of these things, because I don't want to place an implant in somebody and have it fail for the simple reason that their vitamin D levels, for instance, were not optimized for that surgery. So
I love that you mentioned that, because it's very true. Thank you, Dr. Rick Miron. We loved all your presentation very well, and your points are very strongly pointed out and integrated beautifully. Any more questions? Please let us know. Dr. Pavel is mentioning excellent point.
Perfect.
And your lectures is being shared everywhere, and everyone is loving it. Thank you very much, and we were very happy to have you, and we'll hopefully have you a little bit more often too in the near future.
Absolutely. Like I said, I'd be more than happy to do another one sometime. Thank you for having me, and hope everybody's well all over the world, and you guys soon.
Okay. Pleasure. Pleasure.
Thank you.